Gracias. Okay, so are you tired? Thank you for staying so long. I'm very happy that my voice seems to have stayed with me, at least to this point. In this final presentation, I'm going to talk about something of which there are many people at Mayo Clinic better suited to speaking than me, and this is this very rapidly moving field of autoimmune neurology, focusing on autoimmune encephalopathy. And tomorrow at one of the workshops, I'll have some more details about some of these entities, but I wanted to highlight for you some exciting things that are happening in this field, especially the spectrum of disease, some recent epidemiologic studies and viral associations that are quite striking, and then how we look at diagnosis and treatment of these disorders. So, autoimmune neurologic disorders, what are they? Well, simply put, they're neurologic conditions that appear to be caused by some type of aberrant immune response. They're antigen specific, and broadly speaking, they can be paraneoplastic, so triggered, the immune response initially triggered by a cancer, or idiopathic. And they can be unified by an antibody marker, detection of an antibody in serum, CSF, or both. And this is a schematic diagram that gives some principles about antigen presentation from a tumor being kind of a unifying principle here that leads to immune responses that, broadly speaking, follow one of two paths, either the T cell effector path or the B cell effector path with immunoglobulins. And this makes a big difference in both the workup and the treatment, as you'll see as I go along. So, expanding on this, you get the development after antigenic exposure to the immune system of IgG antibodies that target either cell surface antigens like ion channels and receptors or synapses. So the aquaporin 4 antibody is an example of a cell surface antigen antibody. Or, on the other hand, they could target antigens within the cell itself, so in the nucleus or in the cytoplasm, not as accessible as the cell surface antigens are. So examples of these would include, and you'll be familiar with some of these acronyms, ANNA1, PCA1, CRIMP5. These are typically associated, not always, but when you find them, you should be thinking about the possibility of an underlying cancer, and the primary treatment after finding the cancer is to treat the cancer. That's the number one approach. Whereas with cell surface antigens, like the voltage-gated potassium complex, NMDA receptors, etc., they can sometimes be associated with cancer, but the primary treatment for most of these excuse me, is going to be immunotherapy. And they're idiopathic in their onset, in their cause. So how do patients present? They present as you expect to see in other inflammatory conditions. So just like when you learn medicine and you learn about the different types of pathophysiology, sudden things are in neurology, sudden things are usually strokes, and chronic things are usually neurodegenerative, and subacute things are often inflammatory. So these patients present with subacute syndromes. They can have a fluctuating course, spontaneous fluctuation, and they can affect any domain in the nervous system. They're often multifocal, so affecting multiple areas. And so it helps to be systematic and think rostrocaudally about the systems that are involved. And these are slides from my colleague Andrew McKeon in Rochester, and he likes to go through and break these down into cortex, basal ganglia, cerebellum, brainstem, cord, excuse me, lumbosacral roots, dorsal horn, anterior horn, peripheral nerve, neuromuscular junction, muscle, and even autonomic nervous system. It helps to be able to find both risk factors and also an antibody that can make you very confident that this is indeed an autoimmune syndrome. The risk factors sometimes, though, are absent. If they're present, they're usually other coexisting autoimmune diseases like autoimmune thyroid disease, type 1 diabetes mellitus, but also a personal history of cancer, a personal history of cigarette smoking, or a family history of an autoimmune disorder or cancer are also things that should make you think, this person either has had a genetic exposure, they're loaded genetically for autoimmunity, or they have a personal history that could predispose them to paraneoplastic disease. How do you evaluate them further? Well, you can begin clinically by determining the systems that are involved, neurologic examination, mental status testing, imaging, and using electrophysiology to find the areas of the nervous system that are involved. Some of them may be subclinical. And then you do antibody testing. You test in serum, non-neural and neural antibodies. You test in the CSF. And you also, when you're thinking about central nervous system autoimmunity, you're looking, in addition for the antibodies, you're looking at things like the protein, whether there's a pleocytosis, its degree and pattern, and whether there's evidence of intrathecal antibody synthesis, an elevated IgG index, or oligoclonal bands. The more of these clues you find, the more likely it is that either you'll find a specific disorder, specific antibody, or you'll have accumulated enough evidence and excluded other things, you'll be confident that this is probably autoimmune, and therefore it should be treatable, or at least you should try to treat it. So what are some examples? Well, in the context of the neuronal antibodies, the ones that are in the cytoplasm or in the nucleus of the cell, you can see that some of these are the classic paraneoplastic antibodies, anti-HU, anti-RE. At Mayo, these are called ANA1 and 2. Anti-YO, which is the PCA antibody associated with cerebellar degeneration. And you see that cancer is associated with all of these. Amphophyssin, almost always breast cancer or lung cancer. CRIMP5, strong association with small cell cancer. So these are very important to make sure that you are as diligent as you can be in finding an underlying cancer. On the other hand, these synaptic antibodies, some of them have associations with cancer. NMDA receptor antibody, 50% of females that develop this syndrome will have an ovarian teratoma, something you just need to know. AMPA receptor, 70%, one of these tumors. GABA B receptor, 50% small cell lung cancer. These are very, very rare. Relatively speaking, this is quite common. And then there's a host of new ones that have been coming out. I'll describe some of these in a moment, where there's not a consistent oncologic association, or the number is not very high. So what are some of these examples? Well, I'm sure you're all familiar with, with autoimmune encephalitis, causing changes in memory, personality, even seizures, so-called limbic encephalitis. It actually has a broad association with various autoantibodies, some of them intraneuronal and some of them synaptic. One of the most important recent developments has been in the detection and understanding of NMDA receptor encephalitis, which has a relatively stereotyped course. Psychiatric symptoms, seizures, encephalopathy, especially in children, and movement disorders such as choreoathetosis, dysautonomia, can proceed to coma, which can be very long-lasting, but ultimately have a good recovery if treated appropriately. I mentioned the ovarian teratoma. Testing for the antibody needs to be in CSF, especially, can be detected in blood, but needs to be in CSF. Need to find the tumor, take it out if you find it, and then treat aggressively, because most of these patients recover. And it's quite remarkable sometimes how devastated, I mean, you could think that there would be no hope for this person who's been comatose for weeks, and yet they'll recover well enough to, live independently and go to college. There are cognitive disorders that are less discrete or less syndromic, but the primary complaint is a cognitive disorder. It's not typical for a limbic encephalitis, but they may have some other neurologic signs or involvement, tremor, peripheral neuropathy. Thyroid autoimmunity is common. And here you may find synaptic cell surface antibodies, especially these listed here. Not ANA1, that's intraneuronal. Here, this is very challenging because you have patients that have very important complaints, are often unable to work or function very well, and you don't find a tumor and you may not have a very specific diagnosis. You might have something like thyroid autoimmunity and a moderate titer of, say, this PQ type calcium channel antibody, and uncertainty. What does this really mean? Is this associated with their syndrome? So what's very helpful in treatment is doing as much objective testing as you can to find some kind of marker excuse me, that you can track with treatment. So for these disorders, it's usually neuropsychological testing, detailed 2 to 3 hour testing, sometimes longer, that provides a baseline. Then you can intervene with treatment, and we'll talk about that in a few moments, and then retest. And you're looking for an objective response that will then allow you to implement, first of all, feel hopefully more confident about the diagnosis, but also to institute longer-term maintenance immunotherapy. And sometimes these patients have very remarkable improvements. It's not surprising that some of these syndromes are focal or relatively focal and present essentially as an autoimmune epilepsy, with or without more general cognitive impairment. This has been an area of a lot of interest at Mayo Clinic. This is a paper by one of the former fellows in Rochester. Lots of experience with the epilepsy practices at all of our Mayo Clinic sites and our Mayo Clinic neuroimmunology laboratory to better understand these syndromes. I wanted to just share some interesting, these are rare, but interesting phenomena that have been described recently in association with antibodies. So this is one where there's antibodies against GFAP. I mentioned this earlier as an astrocyte, one of the integral astrocyte proteins. And this syndrome is inflammatory and presents with the meningoencephalitis, with or without myelitis, and is very, very steroid responsive. And what's remarkable about it is one of its signature findings on imaging is this very dramatically abnormal MRI. This is from a patient of mine that I was treating actually without knowing really what this was. It was my colleagues in the laboratory that eventually found the GFAP antibody after we had been treating her, without really knowing what we were doing, treating her with steroids and mycophenolate. But you see these radial areas of T2 signal abnormality and enhancement in the brain. This is actually enhancement. And that's a very characteristic abnormality that goes away completely with steroid treatment. Quite remarkable. There's a syndrome associated with glutamate receptor antibodies that seems to be associated mainly with ataxia and brainstem abnormalities, sometimes with cancer like lymphoma. This is showing indirect immunofluorescence, which is how they detect these antibodies in the first place. There's something called DPPX, which was originally not described at Mayo, but here's some experience in showing the very widespread neurologic spectrum of neurologic manifestations. What ties them together is many of these patients had some kind of CNS hyperexcitability. Pardon me, myoclonus, startle reflexes, etc. Most of these were not associated with cancer. And then finally, IGLON5 associated with sleep disorders, also movement disorders, brainstem, autonomic dysfunction, and a stiff person type syndrome. And what was remarkable about this is some of the case series show that these patients can develop this syndrome in a chronic and progressive fashion over many years. So this is further challenging even that paradigm I mentioned earlier about subacute, fluctuating course, etc. What it means is that when we see patients as a neurologist and we don't really understand what's going on, think about the possibility of autoimmune disorders, even if they're unusual, perhaps especially if they're unusual, multifocal, fluctuate, but maybe even the progressive ones, because they might be treatment responsive. In the last few minutes, these are some new and I think very interesting and exciting data that are really helping focus a lot of interest on this field. In particular, autoimmune encephalitis. Now, this first study comes from the Mayo Clinic where if anybody's been to Rochester, they know that it's a relatively small city in a relatively small county in the Midwest. And effectively, almost everybody that lives in that area, in that county, is a hostage of Mayo Clinic. So they get their medical care there, and they have decades and decades of records on these individuals, which is wonderful because it's one of the few places in the United States where you can do population-based studies with a high level of confidence. There just are not other areas in the country, and certainly the country itself, where it's like, say, Sweden or other Scandinavian countries that have a centralized healthcare system. So these data are highly valuable within the United States and broadly, of course. So this study, what they did was looked at serum and CSF collected from people who had been diagnosed with encephalitis and who lived in what's called Olmsted County, so population-based study. And very simply what they showed was the incidence and the prevalence of autoimmune encephalitis was basically the same as infectious encephalitis. So it's, in fact, the prevalence of autoimmune encephalitis, probably because it can be a relapsing and more chronic condition, was actually a bit higher, not statistically significant, but the absolute number was higher. And the incidence is again, not statistically significant. The incidence of autoimmune encephalitis, or at least the level of detection, appears to be increasing. So it will be quite intriguing to see what happens over time, because I often have patients tell me that they've read how the incidence of autoimmune diseases is increasing, and it might be, and this type of study is something that could help test that hypothesis. And then this was an intriguing study that was just published this month in Lancet Neurology. And this was a European study that looked at the association of autoimmune encephalitis with herpes simplex encephalitis, because there had been a number of case reports and small series showing that some patients who developed herpes encephalitis later developed what looked like an autoimmune encephalitis, or even was almost certainly autoimmune because they had antibodies like NMDA receptor antibodies detectable in CSF. So what these investigators in Europe did was they had two cohorts of patients. One was a prospective one where they followed people after they'd had herpes encephalitis. They followed them for a year. They did clinical evaluations, imaging, and spinal taps, I think about 5 times during that year, looking for antibodies, looking for MRI changes, etc. Excuse me. They also had a retrospective cohort, patients that had been diagnosed with herpes encephalitis whom they tested. And what they found was in the prospective cohort, more than a quarter of patients, 1/4, who had had herpes encephalitis later developed autoimmune encephalitis, and it happened quickly. The median was within a month. And most of these had NMDA receptor antibodies. One also had GABA receptor, and 4 were unknown. And in the retrospective cohort, 48 patients, 92% of these patients that had had herpes simplex encephalitis developed antibodies in serum or mostly CSF, and most of those were NMDA receptor antibodies. So, and this is I just felt like I needed to show a picture instead of a bunch of words, but is a very nice paper where you can see the evolution of MRI changes over time in these different cohorts. And the top 2 patients are patients that had herpes encephalitis and then developed autoimmune encephalitis, and the length of time that they had enhancement and also basically encephalomalacia, the degree of encephalomalacia appeared to be greater than in these patients who did not develop clinical autoimmune encephalitis. What they found was in children who had had herpes encephalitis up to age 4, the autoimmune syndrome was usually chorioathetosis, whereas after age 4, the rest of childhood and adults, it was the neuropsychiatric behavioral disorder that we usually see with NMDA receptor antibody-associated autoimmune encephalitis. Also quite interesting is that 30% of patients who had had herpes simplex who did not develop clinical autoimmune encephalitis developed antibodies. Many of these were unknown. But essentially what this study suggests is that we probably need to follow these patients. We generally think of herpes simplex encephalitis as a monophasic infection, treat it with make the diagnosis, treat with acyclovir, hope for a good outcome, and you're finished. but actually you're not finished. So perhaps we should be doing some kind of surveillance in these people, both clinically and with serology over time. It also seems, at least it raises the hypothesis that herpes simplex infection, and based on other case reports, maybe zoster as well, less commonly, can be associated with the development of antibodies such as NMDA receptor antibodies. So herpes simplex is a necessary event, but infection is a necessary but insufficient event, perhaps, in generating this autoimmune response. Finally, what do we do in treating patients with autoimmune encephalitis? Well, we're really in the early days of this with trials of immunotherapy. So as I mentioned before, in all of these, we try to establish as best we can some kind of objective marker, some kind, our clinical examination, the degree of pleocytosis and protein in the spinal fluid, the appearance of the MRI or a PET scan, neuropsychological testing, etc. And we measure that at baseline, and then we treat them and measure it again. What we do is we use a protocol to treat in the short term, usually in the area of 8 to 12 weeks, and then based on the response, potentially a long-term treatment. If somebody responds very well to immune therapy, then we think, okay, we'll then maintain that benefit with, at least temporarily, with some kind of steroid-sparing drug. Cytotoxic T-cell mediated disorders, these ones associated with cancer, generally do not have a good response to immune therapy. So the general approach has to be find the tumor, treat the tumor. My colleagues in Rochester will try treating these patients, often with oral cyclophosphamide, in addition to treating the tumor. The antibody-mediated disorders, if you don't find a tumor, it's important to identify them and treat them early and aggressively, usually with corticosteroids. And our standard is to use excuse me, intravenous methylprednisolone. And we do something like a 3 or 5 day daily course, followed by twice weekly for 6 weeks, and then weekly for 6 weeks. So a total of 12 weeks of treatment. And then we test them again and see how they're doing. If that doesn't work and we're still very suspicious that it may be an autoimmune syndrome, or let's say the patient has type 1 diabetes as one of their coexisting autoimmune disorders, we may not want to use corticosteroids, we'll maybe use IVIG, and in select cases we may use plasma exchange. And then chronically, we try to maintain these patients that respond with one of these drugs. I usually use mycophenolate. I will sometimes use rituximab if I can get it approved. So in summary, suspect autoimmune encephalitis in cases of subacute neuropsychiatric decline, or as one component of a broader multi-system autoimmune disorder. It is as common, if not more common, than infectious encephalitis, and we do have treatments for it. The clinical phenotype is highly variable, and it can follow infections such as herpes simplex encephalitis. So that should alert us to following these patients at least for a few months, if not a year after an event such as herpes encephalitis. Consider whether there's an underlying cancer, assess their risk factors, and go after the cancer aggressively if you need to. I didn't talk about this today, but in cases where there are neuronal antibodies, and let's say a patient has a smoking history, that's a patient where you might want to go as far as doing a PET CT scan of the body to make sure you can't find a small cell lung cancer hiding under the resolution of a CT scan, a regular CT scan. And the antibody profiles, you have to test both serum and CSF. The way Mayo Clinic does this now is set it up by profile. So instead of you having to think about every antibody you're testing, if you send blood or spinal fluid to Mayo Clinic, you basically select the panel that you want depending on the clinical presentation. So we have an encephalitis panel, we have an autoimmune epilepsy panel, we have a autoimmune movement disorder panel, and there are additional panels that are coming. And I think that's going to be the path forward. And then finally, the response to treatment. Thinking about these disorders and early treatment is the key to preserving neurologic function. So with that, I'll end with the sunset, and thanks to my colleague Andrew McKeon, who provided several of these slides for me. I'm happy to take any questions. Thank you.